Hello, my friends. I'm so proud to be part of the first Libyan Emergency Medicine Conference. I wish I could be there with you in person. I'm not very far away, though. I'm right across the Mediterranean in Turkey, but we just couldn't figure out how I could get from one meeting to the other at the same time and space. What I'm going to talk to you about today is give you a picture of what your career in emergency medicine is going to be like, I'll bet, in less than 5 years. So let's begin. Emergency medicine. You're participating in a bold idea that changed the face of medicine. And we have great expectations for the future of emergency medicine in Libya. Let me tell you a little bit about how things started in other parts of the world, and you're going to see how quickly you can make progress. So where did we come from? Well, all around the world, this is how emergency departments were. People confused, hollering, yelling, sick patients everywhere. Nobody was organized, no specialists in emergency medicine. So, in about the 1970s, simultaneously in different parts of the world, emergency medicine was founded. And it was founded in the UK, in Canada, Australasia, and the United States, almost at the same time. Well, emergency medicine is a big idea. It sure needed big spaces to spread. And this map shows you with the stars just where emergency medicine is now founded, thriving, and growing around the world. It's pretty amazing after just 50 years of development. I characterize emergency medicine into 3 stages of growth. And so you can see how you will begin and what you can grow up to be. The stages were first developing the residencies, the second, clinical maturation and academic growth, and the third, population-based care and public health. Let's go into detail about these. What were our issues with emergency medicine residency development? Well, we focused entirely on skills needed for patient care. Medical student interest was the key. We had to turn them on to emergency medicine. Now, all students love the ED because they get to see a lot of patients and think a lot on their own. But what many of us did was at the beginning, we had volunteer times where we could teach students extra things that would make the ED a lot of fun and teach them about emergency medicine. We would teach them about tourniquets, how to do CPR, what ACLS was, and little by little, medical students really caught on. The next problem was establishing the curriculum. Well, what do we teach? How do we teach it? And everybody went to resources, textbooks. Today, you'll go to blogs and posts to help design your curriculum. Then, how are clinical rotations developed? At the beginning, of course, without specialists in emergency medicine, a bit more time was needed on the traditional specialties. But as you will see, once you develop emergency medicine specialists and teachers, more time will be spent in the ED. And the last thing that was necessary for residency development was tracking resident development and competencies. Were they happy with the program? Did they learn what they needed to learn? And were they competent as emergency physicians? Part of it was winning political and clinical battles, or these were battles with organized medicine, with academic institutions, and departments within the hospital. And yes, sometimes they were pretty difficult. Most of the times, things were settled amicably. We moved from that to clinical maturation in phase 2, and it didn't take very long for emergency medicine to expand the scope of clinical practice within the ED, with the use of chest pain centers, stroke centers, observation units, and especially as critical care. critical care really started in the ED. That's where all the cardiac resuscitation began. And it is now moved as a full-fledged subspecialty of emergency medicine and one of our most important clinical needs. As part of clinical maturation, we learned about ultrasound as a daily tool. We learned how to do procedural sedation and RSI. No more calling anesthesia into the emergency department. EM became a clinical authority in the hospital. If we say you need to be admitted, yep, you're admitted. And there was a very important growth in EM informatics, the setup of data systems within each ED so that we can track who we were seeing and what we were doing. The other important part of the second phase of emergency medicine is academic growth. It won't take long in Libya for emergency medicine to become very popular, and residency programs will have to increase to meet the growing need for trained emergency physicians. There was an early focus on resuscitation and trauma research, which really helped emergency medicine grow in academics. But we are the only specialty to focus on early presentations of disease and population health. I want you to think about that a bit. I'll talk about that in a bit. The third phase, as I see it, is population-based care and public health. Advanced degrees in public health have become very popular early in the development of emergency medicine, and they still remain very popular. And the tools we learned from public health enabled us to learn about disease surveillance, to set up multi-center research, to get better with disaster response and management, and to really practice disease and injury prevention in the ED. And when you think about it, we do some aspects of primary prevention, tetanus, rabies immunization for easy examples, but we do a lot of education and interventions for social disorders and to prevent injury. So what do I see? What do we all see as emergency medicine today? And you will be here quicker than you can imagine. Emergency medicine today is a population-based specialty, a prime user of technology, a specialty with unique clinical practice. We're a management specialty, and we practice in any environment. We've grown outside of the ED. What do I mean by population-based specialty? Well, we see all disorders, all ages, any day, any time, care when the rest of our society services have failed. And the ED reflects the age distribution of our community. It reflects the prevalence of disorders. If you work in a Japanese emergency department, you're going to see a lot of really elderly people. In a Turkish emergency department, you're going to see a lot more younger people because of the age differences in those societies. And the diseases are different as well. We identify very early on populations at risk for specific disorders, illnesses, and injuries. We're population-based because we provide resources for special conditions, such as psychiatric and substance abuse, sexual assault, domestic violence, and child abuse. We track outcomes in our ED population and the community population by chief complaint, by diagnosis, and by demographics. And we identify issues for further research so that we can be better and take better care of the health of our community. Very early on, emergency medicine was a terrific user of technology. We developed local and expanded clinical networks. Even in the 1980s, many EDs had their own data sets so they could analyze chief complaints, diagnoses, treatments, and outcomes. And now we have US-wide databases on ED utilization. And our knowledge of technology has enabled us to set up and participate in research networks, which study resuscitation, pediatric emergencies, and infections. And they've changed the way not only emergency medicine, but also other specialists treat a lot of diseases that come into the ED. Emergency medicine is a unique clinical practice. And I've got to admit, most of the community and most of our public health people, most of our legislators don't understand this. It's our job to teach them this. Well, we are a unique practice. Not only do we see minor illnesses, we see any critical illness, STEMI, stroke, sepsis, pulmonary embolism, abdominal catastrophe, whatever we have to respond to within minutes. But we also care for multiple patients at one time in the ED, in mass gatherings, and at disasters. Now, just think about this. If you're seeing a cardiologist, an obstetrician, or a primary care doctor, who's involved in that encounter? Two people, you and the doctor. Not true in the ED, where we will be seeing multiple patients simultaneously who have different acuities of care and different resource needs. That makes us special. How do we do this? We do this by triage. We use standing orders. We can multitask. We're rapid decision makers, and we prioritize patients. Other specialties, well, the priority is, what time is your appointment? Or, I'm in the OR. I'll come down and see your patient once I'm done. We have to do it all at once. We are an integrative specialty, and it takes a while for others to understand this. What does that mean? We coordinate care across specialty lines. We have to prioritize care components between specialties. An example, let's say an elderly patient comes in after a traffic accident, and the reason is he or she had a syncopal episode. Well, what came first, syncope or the accident? What causes syncope? A bradydysrhythmia, a STEMI? What was going on? And how do you prioritize the care for that? That's emergency medicine's job. So we're integrative, and in many cases, we're more than independent because we are integrated. And that makes us the most dynamic specialty that there is. Another thing I want you to think about, we in emergency medicine have a high sensitivity for illness and injury. Somebody comes in, ooh, what's the killer? What could be really bad? Other specialists, however, want a high specificity for their own specialty diseases. Cardiologists want heart attacks. Surgeons want appendicitis. And orthopedists want broken bones. That's the difference in how we practice and how our colleagues in other specialties practice. And if you look at this picture, well, emergency medicine sees the whole elephant. The other specialists are looking for their particular area of interest and specialization. Yes, we are a management specialty. We are decision makers. Admit, not admit, observe. Where do you go at discharge? We are excellent managers because we're seeing many patients simultaneously. What do I mean by managers? We standardize and integrate policies and procedures. We define roles. We supervise. We focus on our ED operations. We organize levels of care. We do data analysis for efficiency in the way we provide care. We do systems-based practice, and we always have to keep an eye out on the big picture. The complaint is part of a body system and a treatment plan, which is part of the health system. Where does the patient go after the ED visit? How do they get there? What happens there to help the patient? And finally, one of our most exciting pieces of growth has been our ability to practice in any environment. Emergency physicians run poison control centers, work in disasters, take care of mass gatherings, work at high altitudes, underwater, are interested in palliative care, and we have fellowships in that, sports medicine, pre-hospital care, and we do wilderness medicine. We are different. Our other specialties often talk about what to do. What about us? We just do it. We work in the most exciting environments. We resuscitate better than anybody. We're the safety net for society. And because of our unique skills, we are the ideal leaders of health systems. We can use our power as a population-based specialty to improve the health care of our communities and of the public. Now, it's our job, very important job, not only just at the beginning of emergency medicine development in Libya, but throughout the career process. We have to show others how we make a difference. We have to tell our stories. Tell the community, tell your neighbors, tell the media, make friends with the radio announcers and with the TV announcers. Tell stories to politicians. Tell our stories to those in public health and how we can be good partners with public health. And tell your medical students, tell your colleagues, tell your residents, we're the best, most fun, and most interesting specialty. Maybe this seems like a lot at the beginning, but it isn't. We tend to focus, oh, I have to start a residency, give these lectures. No, the idea is don't make little plans. Make big plans now. They have the magic to stir men's blood. So I want you to think about that. Get excited about emergency medicine. You're in the best specialty there is. Thank you.